A very good morning and a warm welcome again to the 14th International Symposium on Focal Therapy and Imaging in Prostate and Kidney Cancer, organized by the Focal Therapy Society, and this year held in conjunction with our annual Urofair that's organized by the Singapore Urological Association. Throughout the next few days, we look forward to your participation, and certainly may you forge new and closer friendships. So without further ado, it's my pleasure to invite Dr. Tan Yong Kang, our immediate past president of the Singapore Urological Association, to give the opening address. Dr. Tan, please.
Good morning. I'm glad to see all the friendly faces among the crowd today, both from the region and also even further out internationally. So I just want to welcome everyone to Urofair. This is Singapore's premier urology event. And I want to welcome our regional delegates from Malaysia, from Hong Kong, from Korea also this year, and also further afield from Nepal, and also internationally as part of the Focal Therapy Society meeting. I think many of you have been our good friends over the years, and those of you who are new to us, I hope that we can build friendships in between us, and also I hope that you will get to enjoy the hospitality in Singapore. So Urofair main focus has always been on trying to update urological knowledge within our Singapore urology community. It has also had an outreach to the regional doctors in urology. But as urology has developed over the years, we've developed more and more subspecialties, and sometimes it is inadequate within that 1.5 to 2 days to actually cover the whole spectrum of changes in urology and in our practice. Because of that, I had actually tasked our two co-chairmen this year, Dr. Sundaram and Dr. Tay, to see whether we could do a deep dive into a topic in urology while still maintaining that broad spectrum of knowledge within urology, or updates within urology. So I'm glad they chose the topic of focal therapy, and I'm glad that we managed to collaborate with the Focal Therapy Society this year to bring you this topic. Focal therapy personally has been something of quite an interest to me. Spending time at UT Southwestern with Jeff Kadedu, I did work on RFA for kidneys and then went on to IREs for kidneys. And I've seen focal therapy develop from being sort of like this fringe project among urologists to, ending up within the mainstream context of our practice nowadays. And I'm really excited to see yesterday at the masterclass the really excellent turnout. I think on the sessions that I attended, we were a full house and with standing room participation. I also want to really say and thank the two co-organizers, because I think they've done a really great job at developing this year's meeting. The program is really packed. In fact, they had to extend it all the way to Sunday afternoon, which is about a half day more than our usual sessions. So this year, I want to welcome all our local delegates. I think we've got about 400 plus, including nurses, and our foreign delegates of about 150 people. And for the junior urologists in our midst, those who are trainees, I hope this topic inspires you to think more about urology. That, when I was a junior doctor, I thought we were already, at the pinnacle of urology. And then along the way, I realized that there's so much more to develop. I think a lot of this is driven by both a desire to not just meet, oncological outcomes in terms of survival, but more and more, we want to meet the needs of our patients to reduce, side effects, complications, and morbidities related to our procedures. So, with this, I also want to thank our sponsors, for which, without whom we wouldn't have been able to actually organize this meeting, and to the extent that it's been organized. So once again, welcome to Singapore, welcome to Urofair, and welcome to this Focal Therapy Society meeting. I hope you have a great time here with all the knowledge that you are going to gain today and over the next few days. I hope you'll be able to build new friendships and fellowship with your fellow urologists. And I hope you get to enjoy the warm welcome and hospitality of Singapore. Thank you.
Thank you, Dr. Tan. Next, may I invite Dr. Tay K. Jack, the current Secretary of Focal Therapy Society and the organizing chairperson of this year's 14th International Meeting on Focal Therapy, to give the welcome speech. Dr. Tay, please.
Very good morning. I hope everyone had a good rest last night, especially the faculty. All right, so welcome to the 14th International Symposium for Focal Therapy of Prostate and Kidney Cancer, as well as the Urofair 2024, our Singapore Urological Association's annual scientific meeting. I'm super grateful that to have all our faculty from FTS down, and we had a great day at a masterclass yesterday. So I really would again like to thank all the faculty, organizers, SUA and the FTS for supporting this event and making this possible. I would also really like to thank our organizing committee that have put in a lot of hard work over the year to make this possible, as well as all the sponsors that have come in to do this. So I was going to give this talk on the landscape of focal therapy in Asia. Is there a role for focal therapy? And I think that is particularly unique. Focal therapy has really been taking off in the US and in Europe, and there's a lot of interest to do it in Asia. So to make it pertinent for our local and regional delegates, many of whom are here from the neighboring countries, and many of our local urologists who are interested to start focal therapy and potentially join the Focal Therapy Society, is there really a role for focal therapy in Asia, and how do we define that? And really, I'm just going to give a very brief 5 to 10 minute rundown on this before I hand the floor over to our other esteemed faculty, because really the whole session that we are going to have in these 2.5 days really is to address this particular point. So focal therapy really aims to eliminate the focus of cancer within the prostate while preserving the uninvolved prostate tissue, and in so doing, preserve a man's quality of life. This cartoon depicts various templates that are possible for focal therapy. There are varying definitions. A lot of people would not consider a hockey stick 3/4 ablation focal therapy anymore today. Many people stop the definition at hemiablation, but these are the kind of templates and schema that are being done. This was a diagram that is in the latest Campbell Urology that we've co-authored together with authors from the Focal Therapy Society. So what are the variables impacting the uptake of focal therapy in Asia? I think that there are many patterns of prostate cancer, natural history, and interventions we could review, and I'll go through these briefly. Also, changing demographics in Asia, and lastly, cost and logistics, which are practical concerns for anybody who wants to start doing focal therapy. So this is a chart of the prostate cancer incidence to mortality ratio. I think it's widely known that only 1 in 6 men diagnosed with prostate cancer eventually die from it. And this is really reflected in many countries around the world, especially in more developed countries with a higher prevalence of PSA testing and early detection. Really, we're detecting a lot of prostate cancers in which men don't eventually die from it. In Asia, this is pretty similar. We are in the countries that have reported both mortality and incidence. These are the incidence to mortality ratios that are being reported in Asia. So what really are the prostate cancers that don't need treatment? We talk about this a lot. We talk a lot about cancers that need treatment, but what about cancers that don't need treatment? So this is a systematic review of 29 autopsy studies. That means men who died of natural causes, and they had underwent autopsies, and prostate cancer was found. So what's interesting is that, and we know this, is that incidence of prostate cancer increases with every decade of life. What's also very interesting to me is that there's a large variation in between populations. And that's probably dependent on many factors, such as the prevalence of, not just the prevalence of prostate cancer or genetics of prostate cancer, but also testing, access to care, and mortality from other factors. So this is one classic study looking at the natural history of prostate cancer, widely cited, Johansson et al., 223 patients followed for 32 years, diagnosed on DRE, so this was in a previous era, where 41% of patients experienced localized progression, 18% distant progression, 99% died, of which 17% died of prostate cancer. So I think that's where we get the 1 in 6 from. From the Thames Cancer Registry in the UK, what it was found was that for men with stage 1 cancer, only 11.2% of men eventually died of prostate cancer. And from Albertson et al., we learned that age and Gleason score was really important in predicting death from prostate cancer. Older men were less likely to die from prostate cancer, and men with higher Gleason scores were more likely to die from prostate cancer. And this is the last natural history study from the West that I will show. 10-year prostate cancer mortality reported by Polascik et al. Showed that those with higher PSA and higher Gleason scores were more likely to die from prostate cancer. So what about Asia? Now, I pulled up some data from our own series in Singapore, looking at 204 men who had gone on watchful waiting for prostate cancer. The median age was 73 years. We followed these men for 12.5 years, so not as extensively as some of the other series I've presented, but yet we did find that 84 men died from natural causes and only 19 men died from prostate cancer. So this pretty much ties in with data on incidence to mortality that we are seeing elsewhere. So we also know from contemporary active surveillance series that the risk of dying from prostate cancer while in active surveillance for 3+3 or limited volume 3+4 cancer is very low. Dr. Klotz is here in the audience, so perhaps he'll have some comments on that, whether he still believes that any pattern 4 should be treated, and I think he will share some data on this later. We are very excited to hear that. But what was found was that in a more permissive series from Toronto, where some 3+4 were included, even though the mortality rate was extremely low, it was still higher than that perhaps from the Johns Hopkins series, where they had a very restrictive inclusion criteria for active surveillance using only Epstein criteria. But what's also very notable is look at the treatment-free rate. The treatment-free rate at 5 years, 10 years, and 15 years shows that a large number of these men will eventually undergo treatment. And these are radical interventions, and this is seen across all the series. Now, from the Sunnybrook Toronto data, it was also shown that the intermediate risk cancers that were included in active surveillance seem to be the drivers of failure. These did seem like the patients who failed. Now, notably, this was in the era of pre-MRI, and perhaps MRI will change things. What about intervening in prostate cancer? Does it actually make a difference? We like to cite the SPCG4 paper because for urologists, it helps us tell patients that, hey, treating prostate cancer with prostatectomy saves lives. If you look at SPCG4, and if you look into the details, the benefit was really confined to those who were younger than 65 years, and the benefit was greatest in the intermediate risk group. If you look at a pivot trial, which followed patients for 10 years, rather than such a long period of 23 years, there was no survival benefit of radical prostatectomy versus active surveillance. There was some benefit seen in the subgroup of intermediate risk cancer, and it was quite debatable whether these men had a short horizon of follow-up, and it was also noted that in both arms of the pivot trial, 40% of men died of natural causes within the 10 years. So what about the PROTECT data? Again, showing no survival benefit of prostatectomy versus active surveillance. In this group, nearly 90% of patients had low or intermediate risk prostate cancer. So what are the learning points that we can take back from these natural history studies? I think it does confirm the statistic we throw around. 1 in 6 men with prostate cancer die from it. What we know, higher grade cancer and greater cancer burden probably predict prostate cancer death. But what's also telling is that longer time horizons, aka younger patients, may be the ones that demonstrate a detectable survival benefit in treating prostate cancer. So it's really a balance between the cancer burden and the horizon of follow-up that a man has. And that, again, there may be much variation between populations. So where does focal therapy fit in? And how does this tie into focal therapy in Asia? Now, this is a paradigm of prostate cancer treatment. I think various modifications of this are currently in use in thinking. If you have low-grade, low-stage cancer, basically all options are possible. If you have intermediate or high-grade cancer, but low-stage, organ-confined, you could be cured with radical prostatectomy or radiation therapy. And if you have high-stage cancer, usually those need multimodality treatment. So what about intermediate and high-grade cancer? Well, high-grade is still a controversial point. And they are low-stage at uni or perhaps up to 2 foci of limited volume. So can we treat these with focal therapy? And current guidelines advise us to do this in a clinical trial or an observational study. So this is a chart of various focal therapy cohorts. This is data that is pending publication right now from a meta-analysis that we've written in our group. And over the years, you can see that really we are treating more clinically significant prostate cancer. That y-axis is a proportion of clinically significant prostate cancer in each cohort. And so you can see that as time has gone by, we are really treating more intermediate and high-risk cancer. So I think time will tell when we follow up on these studies what the outcome will be. The other important trend that I mentioned was that of changing demographics. And we are seeing in Asia, similarly to the rest of the developed world, rising life expectancies and more aging. So the chart on the left is a percentage of men who are older than 65 years, and that has really gone up. The chart on the right is that of life expectancy, and that has gone up as well. So this came into sharp relief and was, I think this would be my most important slide. We did a focal therapy study in Asia. This was our phase 2 trial. And we wanted to recruit men. So when we started this trial, I thought that we'd be getting all the young men who want to preserve their sexual function. But actually, the majority, you can see a bimodal distribution of ages here. And a lot of our patients were older men, older than 70. They may not even be sexually active, but they say, hey, I'm older, I'm nearly 75. I don't want a prostatectomy, I don't want radiation therapy, I just want to age gracefully. Can you just treat that spot and let me get on with my retirement and enjoy the rest of my life? So I think that was an important lesson for me because it made me realize that perhaps the other group that we can do focal therapy on are really our aging population, where they just need to have an adequate amount of their cancer treated, and then they can age gracefully. So our group also looked at transcriptomic profiles between the East and the West, looking at East Asian men and Caucasian men, and we did find that there was quite a lot of difference in prostate cancer genetics. And we'll have a session at 3 o'clock later on, exploring this issue in depth, so do stay on for that. Last, I talked about the cost and logistics of focal therapy. So there was, this was one of the only publications that I found on a large series done by Reddy et al., finding that actually focal therapy was more cost-effective than radical prostatectomy or radiation therapy. So in conclusion, I think with aging, there will be more prostate cancer detected with a longer life expectancy. I think the question is, will we extend treatment to older age groups? And with more PSAs and MRIs done, we will find smaller tumors at an earlier stage. But with more accurate diagnosis, more intensive follow-up, this is going to cost health systems a lot more. And the question is every health system suitable for us to implement focal therapy? So Asia, like the rest of the world, is heterogeneous. So I think my advice to the group is take the lessons that you learn from the data that's going to be presented, but we have to apply this evidence to trends specific to our own communities. So without further ado, I'm going to hand the floor over to the scientific meeting and going on to our next session to talk about focal therapy, the past, present, and future. Thank you so much. Can we have the moderators for the next panel come up, please? Dr. Peters. Do you guys have the biographies? Do you have the biographies? Right, so our next session is a plenary lecture by Dr. Thomas Polascik. Dr. Thomas J. Polascik, I have the great honor of introducing him. He was my fellowship mentor, and he still is my mentor. He's the immediate ex-president of the Focal Therapy Society. He's also recently awarded the Lawrence C. Katz Distinguished Professor of Urologic Surgery, Distinguished Professorship. And he's also Professor of Radiology, Duke University Medical Center, Director of Surgical Technology, Duke Prostate and Urology Cancer Center. And I have had the great pleasure of working with him. I've learned so much from him, and I can think of no better person today to deliver this talk on focal therapy, the past, present, and future. Dr. Polasik, please.
Thank you, Dr. Tay, Drs. Tan, esteemed members and guests. It is my privilege to deliver this address, Focal Therapy for Prostate Cancer, the Past, Present, and Future. I have no relevant disclosures for this presentation. So why has prostate cancer focal therapy been expanding? I think we need to look at breast cancer. This comes from Lori Klotz's work. If you look at the timeline for breast cancer, which is in the upper part of the figure, early on, there were pioneers. They had a many years jump on prostate treatment, and then it progressed to early adopters, and then a couple clinical trials, and then it was taken up and it was embraced by the community. So very similar, prostate cancer focal therapy is going through the same. Again, we started many years later, probably the mid-1990s to around 2000 with Gary Onick's seminal work and others. And then we got into the early adopters. We started running clinical trials, and we're at the point now of doing some RCTs, and we're still looking for the adoption by the community and our regulatory bodies. It all begins with device development. I think at this point we have a number of devices, as you can see, and we're more coming on the market. We had some first focal therapy meetings. I wanted to spend a few minutes talking about a few of these devices. The first is cryo. It's been around a long time, since the 1960s. It first showed avascular necrosis and cell death in 1966. This was done in an open fashion under visual monitoring. Although it is the oldest clinical tool for prostate cancer ablation, there were problems, significant problems with the monitoring, and the complication rates were high. In the 1970s, they used digital guidance, but it wasn't until 1993 where this team, Gary Onick, Jeff Cohen, Boris Rubinsky, and John Baus, put together the first series of percutaneous ultrasound-guided cryoablation in 1993, and by 1997, the FDA cleared it for prostate tissue ablation with a specific indication for prostate cancer. HIFU had a similar origin. In the 1980s, the HIFU project was started, trying to develop a minimally invasive tissue treatment without compromising quality of life. It began with BPH, and a year later, prostate cancer was treated. 1999, multi-center studies on toxicity and cancer control, resulting in 2015 an FDA 510(k) clearance, but it still ablate prostate tissue, not specific for cancer. IRE, similar developmental timeline. It was first noted in the 1970s that the dielectric breakdown of the cell membrane was due to an induced electrical field. 2007, they did some ablation in dogs showing no glandular elements, and by 2011 was FDA cleared, again for prostate tissue ablation. FLA was around since the 1960s. In the 1980s, it was first clinical trials in brain and liver. 1993 was like a landmark year for a lot of these technologies. Here's another one with FLA, initial applications for prostate ablation. And then in the 1990s through 2000s, several of the laser systems received FDA 510 clearance, again for tissue ablation. With all this going on in the backdrop, we held our first International Focal Therapy Summit. At that time, it took a lot of courage. It took friends and colleagues to even do this. We plotted on, and we rotated meetings between North America and the Netherlands, and then Japan joined in 2019, and then the rest is history. I wanted to make a few comments about bridging from past to present. The concept of the index lesion, I think, was a game changer. We also saw evolution in imaging, biopsy techniques, and grade group 1 disease was demystified. The concept of the index lesion, I think, put to rest the concern of multifocality in prostate cancer, because the pathologic characteristics of the index lesion are often the best predictor of the natural course of disease. Metastatic prostate cancer is mainly derived from certain aggressive clones originating in the primary lesion, and we can take advantage of this. At the same time, there was parallel evolutions in imaging. In 1963, the first TP ultrasound examined the prostate, leading to the first trust biopsy in 1981. Similarly, MRI underwent an evolution. 1971, first MRI application in animals to detect cancers. 1982, the first report of appearance of BPH versus prostate cancer. And in the 1990s, the development of DCE and DWI sequences. At the same time, about a decade later, we have the fusion biopsy in the 2000s, and then the PIRAD scoring began in 2012, and we're now up to the version 2.1 in 2019. All these things coming into play to help provide the foundation for prostate focal therapy. This is an important study from the NCI with about 1,000 cases. Subjects had both fusion and extended conventional biopsies, showing that MRI fusion detected more clinically significant prostate cancers than conventional biopsy, but the combined approach detected an additional 22%. And you can see this here, the evolution over time, and it is for this reason that we still do a conventional biopsy with image guidance to detect those additional 20% clinically significant cancers, with the implication that we cannot rely yet on targeted biopsies alone. There should be an appreciation for the evolution of the Gleason grading system, because this was paramount too. We started off doing focal therapy on grade group 1, but in 2005, there was a modification of the Gleason system whereby cribriform and ill-defined glands were converted to pattern 3 category to 4s. And for this reason, you can see in the bottom left, what was the result? Here's a study of 2,500 men using contemporary Gleason grading, and they found that EPE was only detected in 0.2%, and none of these men with true Gleason 6s had seminal vesicle invasion. Similarly, in terms of metastasis, looking at 3,600 men with true Gleason grade 1 tumors, none had lymph node involvement. The goals of focal therapy have evolved towards minimizing unnecessary treatment, as you can see from 2012 to 2019. Initially, we were trying to eradicate all cancer. Now we're trying to control the aggressive cancer, use surveillance, and retreatment if necessary. This is a lot of Lori Klotz's work about MR visibility as a predictor. You can see here about MRI visible and invisible tumors. Clearly, visible ones have a worse natural history, and it leads one to the question, should we perhaps wait until some of these tumors become visible before treatment? I think we'll answer that in the future. Pioneering trials then went on. The Focal Therapy Society was established, and we had related collaborations. This is a very busy slide, but it shows many of these trials, because people say we need RCTs. Well, these are abandoned trials for localized prostate cancer that really never came to fruition, and the most common reasons for trial closure are lack of physician equipoise and patient choice. For example, PART was a randomized clinical trial for men with intermediate risk prostate cancer, randomized to RP versus HIFU, but only 25% agreed to be randomized, and similarly, 22% of the men who were randomized to RP withdrew their consent. So patients really don't want to be randomized. Here's another trial. FARP is a randomized clinical trial for men with MR visible, biopsy-proven, unilateral, intermediate risk prostate cancer with a 1-to-1 randomization to ablation using HIFU or TULSA or robotic prostatectomy. But 27% of those in the robotic prostatectomy arm declined RP treatment. I mean, this is very telling. This is what our patients are telling us. We see the same thing in my institution. A lot of these patients are not willing to be randomized. They are typically educated before their visits, and they're not impartial about their choice. So focal therapy remains attractive to patients, and it is very difficult to randomize men. What can we do? How do we run these RCTs? What's the solution? Well, maybe we can go to regions of the world where perhaps the design of the trial of using ablation and standard of care matches the health system and the patient culture. I think there's fewer sites where we can do this now, but maybe we can find some. Or, though of lower value, we can run RCTs between the different ablation modalities, but I think this is less interesting. So the Focal Therapy Society was brought about with the aims to advance and position minimally invasive and image-targeted cancer treatment in a safe and effective gland-preserving manner to extend and maintain quality of life. In 2019, the FTS was founded, and we officially partnered with the Endourological Society. I would recommend that you get involved, join, become a member, and serve on the committees. We need lots of help to move this forward. Nothing happens without your support. There's no other magic. There's many committees that you can participate in. We now have a registry. I firmly believe that clinical registries play a crucial role in establishing robust evidence because not everything has to be an RCT, and it will also lend credibility to your practice. So here's two guidelines by the EAU and the AUA, both recommending that if you do focal ablation, it should be within the context of a clinical trial or on registry. So at Duke, all of our studies are on registry, meeting these guidelines. And you can too if you want to put your patients on registry. We've also put out a number of publications, white papers. Here's one on summarizing the world experience on primary whole gland ablation for treatment of clinically localized prostate cancer. It's a Focal Therapy Society best practice statement looking at the world experience of HIFU and cryo. Here's another white paper that came out by Amir Labachi and colleagues, Standardized Nomenclature and Surveillance Methodologies After Focal Therapy and Partial Gland Ablation. And all these publications are international multidisciplinary consensus. So please join us and participate. We have some exciting new ones on the horizon. We just wrote one with about 90 international experts as co-authors, Salvage Ablation for Radiation Recurrent Localized Prostate Cancer, a Focal Therapy Best Practice Statement, and we wrote our first official abstract from the FTS registry on the experience of cryotherapy, which was accepted by the last AUA. So please come join us. There's a lot of work to be done. We welcome industry, thought leaders, clinicians, government bodies, et cetera. Now we have some unresolved issues that we still need to work on. We still need to work with randomized clinical trials as best we can. We still have to sort out MRI visibility versus invisibility. An interesting concept is maybe we can monitor these on surveillance until they become visible. We need to get that data. Jack Tay presented the cost effectiveness. So there is evidence that focal is actually more cost effective, but as you know, costs are local. So you have to work within your own environment and hospital setting to determine what the costs are for you. AI is going to become more prominent. It's going to, I think, lift this to the next level. We're not really certain what that's going to mean, but it's going to be part of the focal mantra. And then we haven't had many liquid biopsies or biomarkers. We have two good papers that have been recently submitted, and we expect more biomarker work to come up in the future. So I'd like to thank everyone for your help and participation. I'd also like to invite you to the next North American meeting, which will be in September 2024. It's going to be a combined meeting between SIRS, the Robotics Society, and the Focal Therapy Society, looking at technology and how that can help us in our practices. We'll also have the FDA there to give us an update on what they think about this topic. Thank you for your attention.
Thanks, Tom, and great talk. Only some questions from the audience.
If not, I have one. Yesterday we mentioned about the other methods, just such as PSMA PET or the micro ultrasound, other than MPMRI. What's the role for that kinds of imaging method for the focal therapy?
Yeah, I think we need to figure all these out. There's definitely going to be a role, but you know, like many of us don't have access, or we don't have payers that pay for PET like they do perhaps in other areas of the world. So we're going to have to do research and figure it out. We at Duke have used RFIG, acoustic radiation force impulse imaging, looking at tissue stiffness. So there's a lot of new technologies that are being developed, and will definitely have a role. We just don't know where they fit in this. But it's a very exciting time and a very exciting field to be part of.
Thank you very much.
Thanks so much, Dr. Polasik.